We're gonna
get started.
Okay, for the proper attire for the graduation dinner is either a coat, like a sport coat without a tie or a suit. So just something nice, something that you would wear in the clinic. I'm also going to pass around the sheet for signature or the picture in your yearbook. So if you don't want to be a blank spot for you in the yearbook, please sign it. Appreciate it. Thank you.
Can you hear me in the back? Okay. We're going to go ahead and get started. Thank you very much for your participation. My name is Sandra Sanchez-Reilly, and I'm the Palliative Care Program Director at the University and the VA. I am really very excited that you guys are here. This is the first required palliative care course that the university has, and you happen to be the first class. Thank you very much again for being here. We are going to go ahead and get started. These are the course objectives for MEDI 4115. We will be discussing a couple of details later. It's a lot of print, so I just wanted you to be aware of the course objectives, which are also located on your syllabus Blackboard. We're going to be focusing on communication skills, interdisciplinary team approach, and then the multicultural practice of medicine. We think those are essential topics that a future intern needs to learn and be an expert in. Communication is going to be a big focus, particularly delivering bad news and in family meetings. And we're going to be evaluating your progress, and that's why you have to take a lot of pre and post tests. And I'm sorry about that, but that's kind of the only way that we have to evaluate you. The grade that you obtain on your pre and post test will not count in any way towards your grade. This is just to evaluate progress. So this course really shouldn't be a waste of time. Definitely not an OSCE, so that's not what we want. Although the course description said there's going to be an OSCE, it's not really an OSCE. We're not measuring your encounter, we're not measuring time. We're going to give you direct feedback of something that you're going to be doing on a clinical encounter. By the way, you don't look at all like these people. We don't want you to become a palliative care specialist if you don't want to. All we're trying to accomplish is for you to have basic skills to deal with terminally ill patients and chronically ill patients. So there's no way of me having you be a specialist. We just really want you to acquire a very basic set of competencies. And again, yes, this is just tools for the new intern life and for your professional life. Our objectives for today, we're going to introduce the concept of palliative care for all patients with chronic disease. We want to acknowledge the different benefits of palliative care as it relates to patient, caregiver, cost effectiveness, and quality of care. We want to describe the different educational efforts and interdisciplinary approach when we're caring for terminally ill patients and their caregivers. And now, I'm not going to be the one who will be given part of this lecture because we have a clinical case and actually a personal story. This is Mr. Enrique Trevino, and Mr. Trevino, this is when he was about 60 years old. He's a very successful man in Laredo, Texas. And Mr. Trevino was married for many, many years, had two wonderful children. He worked as a railroad worker, and he was a very active member of his community in Laredo. He was also part of the city council there. This is Mr. Laredo on his 50th wedding anniversary. And this is Mr. Laredo with his, Mr. Trevino, thank you, sorry about that. And this is Mr. Trevino with his wife and his granddaughters. And this is Mr. Trevino a few months ago. Mr. Trevino is 83 years old, and clinically he has past-making history of diabetes, hypertension, CHF, he has an ejection fraction of 30%, had coronary artery disease, had a pacemaker placed, peripheral vascular disease, had a right PKA and has a prosthesis. He has chronic kidney disease and his creatinine level was 2.3. and he underwent an amputation, a partial amputation of his left foot several months ago. Mr. Trevino was previously very functional. He was independent of his activities of daily living. Anybody activities of daily living? Eating? What? Bathing? Toileting? Very basic things that you do to be at home. And most of his independent activities of daily living. He was taking care of his wife, who also has several comorbidities, and was able to interact very well with his family members. He used to use the phone several times, speak with his grandkids, attend all the family celebrations. He lives with his wife for more than 50 years and has 2 daughters. And he started experiencing pain and left lower extremity coldness and several ulcers. So he had a hallux amputation that had to be advanced to a TMA. Had several complications after the surgery. He developed post-surgical delirium. He had urinary retention. He developed infections in the hospital and had pressure ulcers. After the admission to the hospital and returning home, the patient was very confused. He was weak. He was unable to walk or transfer due to severe pain and weakness as well. From being independent in his activities of daily living, he required assistance in all his activities of daily living. He required 24-hour supervision, so family members had to deal with working out a schedule to take care of him and having to hire caregivers to take care of him. He was not able to care for his wife either. He had visual hallucinations. He started seeing strange people coming to his dining table to sit with him at breakfast hour especially. He was seeing insects coming out of his mouth and birds flying around him. He had marked weight loss. If you remember the picture of Mr. Trevino, and you can see him now, he had poor appetite and he did not sleep well. He had worsened renal function, had an open wound after surgery, and another surgery for a higher amputation was proposed by his vascular surgeon. So what are the things that we can do for Mr. Trevino? We can diagnose mental decline, so we were able to diagnose depression and dementia, and we were able to work on his pain management to relieve his suffering and make him more comfortable. We were able to manage his anxiety, and we were able to treat his depression. We were able to help with weakness, and we were able to have lots of discussion in regard to advanced care planning, such as end-of-life issues, readmission to the hospital, rehospitalization for surgery, and dialysis. We used an interdisciplinary team approach. We had a social worker, we have other members such as psychologists, nurses, and nutrition and medicine to help with Mr. Trevino's medical issues. And now we're very thankful to have Mr. Trevino, his daughter, Mrs. Delgado, and his caregiver, Ms. Vijay Gomez, who will be telling you a little bit about themselves and how this process went. We are very thankful because Mr. Trevino had agreed to be a teacher to you all, so thank you very much.
Good afternoon. I am Enrique Henry Trevino, and I'm 83 years old. I'm a diabetic, have kidney and heart problems, and poor circulation in my leg. In 2000, I suffered a slight heart attack. At that time, they discovered an infection toe on my right foot. My heart and kidney were also failing. So I decided to come to San Antonio for other medical opinion. Under the care of many doctors, I did well for 10 years. In May 2010, I lost my left toe. I became depressed and started to see bugs, flying, birds, and different things in my room. And people that were having breakfast with us in the morning that didn't exist. I lost interest in reading, watching TV, talking on the phone, or visiting with family and friends. I even lost interest in eating some solid food. I could not get out of bed and dress without assistance. My daughter decided to seek the advice of another doctor. This doctor reviewed all my health issues. My daughter Lucy will explain what measures were taken to restore my physical and mental health. I wish you all the best of your medical career. Do not work independently, but together when taking care of your patients, especially your senior citizens. Thank you.
Good afternoon, and thank you for your patience. My sister Anna was unable to attend. Dr. Riley had asked for both of us to be here, but due to work circumstances, she was not able to come this afternoon. I do know that, let me take up from when my father became ill, lost his toe in May. That's the first time we ever heard of palliative care. We were at the Methodist Transplant and Specialty Hospital, and it was mentioned to us, but nobody ever followed through. We kept on asking that when were we going to, when was somebody going to come talk to us about that? Because we knew, my sister and I were very fortunate that when my father lost his leg 10 years ago, 2000, at that time they signed all of their medical directives. They did their DNR. They told us exactly what they wanted or what they did not want. So we already knew, we already had a frame of mind of where to take this, but we didn't know where to go, and that's where we were stuck. The family physician, that was my father's family physician for many years, even prior to moving to San Antonio, he no longer was doing hospital visits. He just primarily did his own office care. So we were lost. We had nobody overseeing his entire care. We saw he had many specialists. Even before he took ill, he would come to San Antonio, because this is where my sister and I took up residence, and we felt that always it was very important to get another opinion. So he had his doctors in Moderator, but if we needed to, we would bring him into San Antonio, and they would seek help as well. Well, in the year 2000, not only did he lose his leg, he was also diagnosed with stage 4 renal failure. He had prostate cancer, and of course, heart problems, and besides being a long-term diabetic, long-time diabetic, being a Hispanic background, and I'm honest to say, stubbornness that comes with just being, being male, and it's just something that I think everybody stands in line for. So, so those factors didn't contribute to his poor health, but his spirit was still there. As he lost, then in May 2010, when he lost his first toe, yes, you were probably asking, well, did he seek wound care? Yes, he did do that. He went to the hyperbaric. He had very good doctors there, and they did what he could. But then after he started experiencing hallucinations, he tried to go back to see that if the wound would heal with the use of hyperbaric treatments. And he had a panic, an anxiety attack. So we had to consider that. We had to think, okay, even though his mind, his mental status is changing, he still could tell us that he did not want to go back. So we had to honor his wishes. That's very difficult as a senior parent. Sorry. I teach kinder, and believe me, I cry a lot, even with my group. So my sister and I had to think about this and consider what they had asked of us and what was the right way to turn. And thank you. We decided, or not that we decided, we are very true to our faith. As doctors, and I'm not going to tell you which faith you should practice, which faith you should believe in, but you need to believe in something stronger than yourselves. As my father mentioned, whether it's your co-workers, and not only the co-workers that have the same title as you, but anybody that's working around you and beneath you. It's very important to listen to what they have to say and what they have to offer. I, as a teacher, had the opportunity to take my children on a field trip, and at that time, an angel sat next to me, and we were talking. And that angel said, I can offer some service. And actually, we were talking about, we first started the conversation because I have my eldest daughter. She saw in one of the pictures. She'll be graduating from Texas A&M this May, and we were talking about what she was going to pursue. Unlike you all, you seem to have gotten yourself and going into a pace. She seems to want to take a year off. I don't know why. Anyway, for a parent, is all I know is the income is going to stop there, our income to her. Anyway, so we bought at my father's care, and she offered to speak to my sister and I. So we did. We sat for maybe 3 to 4 hours, and just having somebody listen to us that knew that had the experience in palliative and geriatric care. I mean, we walked away from that evening feeling so much better, because as you saw my father in that last photo, that's when he was at his lowest. We then began seeing our new physician, my father's new physician, in October, I believe, was the first visit. Then came November, and he was seeing a neurologist through the summer. He was seeing an endocrinologist for his diabetes and for his high cholesterol. He continued to see his nephrologist, his podiatrist, his vascular surgeon. We were just going and going and going. Alma, not only a friend, but our caregiver and driver, was completely just between my father and my mother's call for taking them places, and my sister and I would alternate going and meeting them at the different appointments. This helped. There was, I think, one of the things for palliative care is cost effectiveness. Well, one of the things my parents did do that also helped us a lot was they made sure and paid for health care and nursing home insurance. So we knew we had that little buffer. My mother they both grew up in the Depression, so I think they knew what it was to save. Or they didn't, because I don't know, they knew they were going to live this long. We don't expect to. But you will be the doctors of the potential baby boomers that are going to be living. So you know that you're going to be, this age group is going to be one of the primaries, 80s to the 90s is what a lot of doctors are going to be seeing in the future. So at that time, we sat with our new physician, and she went over many things with us, put us on. I went ahead and asked the question that nobody wants to ask. How much time, just from what you hear, you haven't seen any of my father's medical history, any of his lab results, what time frame can you give us? And we were told possibly the holidays or thereafter, maybe 6 months. So I know the one thing was asked, my question was asked to my sister and I, what do you want to see your father leave with? If he was to die, how would you want to see him, leave this world? And my answer was that his mental status would not be the way it was. Well, long and behold, medicines were changed. We also asked the question, was very important. I thought that we asked this question. My father had a list of medications, 20 plus, he was taking daily. Well, when his health deteriorated, it was very difficult for his caregiver at home to want to give him the medicines, for him to want to take them, due to the lack of appetite, to the depression, to his his own will to just to keep going. So we went through that list, and with the help of his nephrologist and his new physician, they both agreed on things can be taken off. Well, I don't know if it was that, the power of prayer, but my father's life turned around. In December, he picked up the phone, he was calling all his friends, his appetite picked up, he was back to doing things slowly but surely. He was regaining the way we once knew him. So we were very happy because we said, if his kidneys were to fail any time, because that's one of the things we know, that then his nephrologist and himself decided, my father said, I don't want to ever be a dialysis patient. So for 10 years, my father has stayed off of dialysis and has been steadily stage 4 renal failure. Why? We don't know. But his creatinine elevates a little, but always seems to hold. Even though it's a high creatinine, that's a normal high creatinine for him, if I'm not making any sense. That's a normal number for him. So then we saw my father's health improving, and we know he's never going to be 100% better, but we know if his life were to end, at least he would have gone with a better memory and a better self-respect for himself. And I know for my mother and for my sister and I think for our other family and friends, we are very happy with the care that we are receiving now. And that all falls under palliative and geriatric care. Thank you so much, and congratulations on another milestone. I hear you all graduating in May. That sat with me on that bus that day. She didn't want me to say, but this was her. So thank you. I have to leave. My children are waiting for me. I have 23 kindergarten students that, and I know that we always think, it's okay, I think I'm louder. I think we always think, and even we get to my age, to my dad's age, we always say that we think we know it all.
Without the microphone, we can't hear her.
Sorry.
Sorry, Hardington. I know we always think that we know it. We think we know everything there is to know. But believe me, unless somebody is walking in God's shoes, it's virtually impossible. Thank you so much. Have a good afternoon.
Has to leave, but I think it's on. Sorry, Mrs. Delgado has to leave, but I wondered if you all have any questions for her as a family member and a caregiver of somebody who is being so sick and remains to be so sick.
Good.
Okay. Thank you.
Thank you. Good afternoon.
Okay, we'll continue on, and again, thank you so much to Mr. Trevino and family for all their help. And just to show you a picture of what palliative care is about. So again, just thank you for what we did for him. We treated his depression. We recognized that he had issues with dementia, and we started medication for that. We managed his pain, managed his anxiety, managed his depression, began to build on his strength so he could be less weak. And we had lots of discussions with Mr. Trevino when he was able to participate, and with different family members. Which brings me to what is palliative care. So palliative care is interdisciplinary care that aims to relieve suffering and improve quality of life for patients with advanced illness and their families. Please notice that it can be offered at the same time with other appropriate medical treatments. So palliative care is not for dying people. It's not for us to be called 2 days before they die. You can still do surgeries, you can still go on dialysis, you can still give other medications, but at the same time, we can start planning for the future, doing lots of communication stuff and helping with symptoms. So if you call us, or if you consider palliative care for your patients, palliative care is not a death sentence, it's not only for dying patients, has a lot to do with symptom management. As Mrs. Delgado and Mr. Trevino mentioned, they wanted to build good memories, and they wanted to be able to be comfortable. So it's a lot about symptom management and about improving quality of life. And it has an interdisciplinary approach. We work with social workers, with pharmacists, with chaplains, with nurses, with other different professions that are so beneficial to the care of our patients. Lots of family involvement. We work very much with the family, and of course, we see many, many older patients. So what is the difference between palliative care and hospice? There's not a lot of difference, but somewhat, if you will. Non-hospice palliative care is appropriate at any point during serious illness. You don't need to give a bad prognosis. We don't need to choose between treatment approaches. Hospice is a form of palliative care, so it's a small piece of palliative care, specifically designed for people who are terminally ill, meaning they have few weeks to few months to live. They must have a certified prognosis of 2 physicians stating that they are likely to die within 6 months. Now, what happens if they live 7 months? Nothing. You just certify them again. But to the best of your knowledge, you just have to say that these patients are terminally ill. They are not eligible for curative treatment at that point. This is what we used to think in the old system. So let's take Mr. Trevino as an example. And Mr. Trevino was diagnosed with multiple amputations related to his severe peripheral vascular disease. And then he was diagnosed with severe renal disease, and then he was declining and having delirium and having so many complications. And one day the doctor said, Mr. Trevino, there's nothing else I can do for you. I'm going to refer you to hospice. And then 14 days later, he passed away. How would you feel if your family member was treated that way? Feelings? Nothing? No feelings? Okay, I can tell you, I would feel abandoned. But this is the model for palliative care, in which Mr. Trevino was diagnosed the same year with peripheral vascular disease and had multiple complications and amputations, and was diagnosed with dementia and had delirium. And at the same time that this happened, we started to talk about goals of care. What would he and his family want for himself? How can we improve his quality of life? How can we improve his symptoms? And as the time went by and Mr. Trevino becomes more and more sick, eventually palliative care will take over and he will be referred to hospice. We're not there yet, but the family and Mr. Trevino knows that we are heading into that particular direction. Why palliative care? Because of quality. It's, nowadays, you probably have heard of JACO, and you are going to hear more and more of that when you become a resident. Quality of care is extremely important. Quality is defined as care that is beneficial, patient-centered, efficient, timely, safe, and equitable. We were able to improve Mr. Trevino's quality of life and quality of care. Again, we were able to manage his pain, his anxiety, his depression. We were able to have tons of discussions for them to know what they wanted and to try to enhance the principle of autonomy that you are seeing in ethics as well throughout this month. We have an interdisciplinary team approach, wonderful team members that were able to help us to enhance our medical care and provide Mr. Trevino with a better quality of life. So why palliative care? Let's talk about patient and caregiver burden, what we call the principle of autonomy. Let them decide. This is what patients want. Patients want their symptoms to be controlled. And they don't want to have a prolongation of the dying process. And they want to achieve the sense of control. They want to be able to make decisions and to tell you what do they want in terms of their medical care. And they want to relieve burdens on the family, and they want to be able to have the capacity of strained relationships with their loved ones. This is a symptom burden assessment that was done on different patients that were admitted at several academic medical centers. And what you can see is that these are very common diagnoses in hospital admissions. Colon cancer, liver failure, lung cancer, multi-system organ failure. Within the 50% range, and a lot of them 60%, had severe pain between hospital days. Now, if you ask, maybe not yourselves, but if you ask your patients, where do they want to die? What would be the place of perfect death for them? I can tell you, I have asked many of them, and they say they want to be home surrounded by their family. Raise your hand if you want to die in a medical ICU with tubes, machines, and beeping. Anyone? I didn't think so. So you have seen that, you have heard that, you have been there. 85% of our patients are dying in hospitals or long-term care facilities. We're not doing what they want. Just to give you some more numbers, this is the support study, kind of the largest study that has been done for terminally ill patients. 9,000 patients with life-threatening illness, 50% of them died within 6 months of entry. Half of those patients died in severe pain. And 38% of those patients spent more than 10 days in an ICU, in a coma, and in a ventilator. Again, we're not giving our patients what we want. Our family members said also that they felt that they were not supported, that they feel that they didn't have a good shared decision-making process, that they didn't know what to expect, and they weren't respected. Again, this is just more data that supports that. So again, not supported, not respected, not enough contact with us. This is what they would have wanted. They would have wanted their loved ones' wishes to be honored. They would have wanted to be included in the decision-making process. They wanted support and assistance at home. They wanted practical help. So they wanted us to think about, how am I going to transport Mr. Trevino to a medical student's lecture? What place are they going to park the car? You know, that's something that we, as physicians, need to think about. This is not, let's go to social work and let them deal with it. So we as human beings, or because we were human beings first, we need to think about just needs that our patients may have. Transportations, medicines, equipment, personal care needs, honest information. Patients and family members want to have access to us. They want to be listened to. They want us to acknowledge privacy as a very big principle. And they want to be remembered and contacted after the death. This is what we see in America. The article is slightly older, but that doesn't mean it has changed a great deal. A lot of the family members lose their savings, they lose their income. There's a major life change event if someone in their family becomes sick. In America, we currently have 25 million caregivers deliver care home to a seriously ill relative. They spend about 18 hours hours on delivering care, and 60% of them work full-time. 61% of them are women, 33% are over the age of 65, 33% have very poor health themselves, and 87% are applying for help. Talking about comorbidities, stress caregivers are a significantly increased risk for death and major depression because they have to deal with so much stuff. And if we were to pay them about $10 an hour, we would have to come up with $150 billion. Not good. So now that we're talking about money, let's talk about the principle of justice and why palliative care money. This is what you are going to graduate into. Medical spending in the United States, $2.4 trillion in 2008. Believe me, it's not getting better for this year. The numbers are not out here, but it's very bad. We have a population aging, such as Mr. Trevino, with multiple medical conditions. We have a lot of growth in patients in need. We have new technologies coming up. New technologies are expensive. And we have a very antiquated payment system. We have a crisis. $2.4 trillion in 2008. That accounts for 15% of the gross national product, rising to 20% in the year 2015. It is the highest per capita spending, but we are really bad at quality indexes, 20th in quality. And if you look at that, 63% of Medicare patients with 2 or more chronic conditions account for 95% of that particular spending. Just to give you, if you are a graphic person, that will show you that actually costs are pretty much rising. This came in the New York Times a few weeks ago. If you compare the different developed countries with our country, which is the one on the railroad print, you can see how exponentially our expenses are growing. There have been articles in Palliative Care has demonstrated that palliative care can actually save money to hospitals. So if you just call a palliative care consultation, or if you don't have access to a palliative care consultation, but try to do palliative care, which is what we're trying to get you to learn on this course, you can see that if you compare, for example, the ICU cost on the light discharges versus the hospital deaths as well, you can pretty much see that the money saved is exponentially high. So we're talking thousands of dollars per patient. If you were just to have a simple conversation saying, what would your loved one want? If he or she was able to make a decision, what would they want? Do they want to be on a ventilator, continuing with dialysis and tubes and machines, based on what she or he was or is? So again, it's all about family meetings. It's all about communicating. It's all about trying to relieve symptoms. Palliative care is cost savings. Why? We try to support transitions to a more appropriate care settings based on the patient's values. I show you that actually palliative care lower costs, and it also improves continuity of care between settings. So we're able to try to determine what would be the next place for this patient to go and have care at. Why? Because we clarify goals of care with patients and families, because we help families to select medical treatments and care settings that meet their goals, and we try to assist them with very difficult decisions. So now, education in palliative care, and this is why you're getting this course. The goals of education is to increase knowledge and expertise, to improve communication skills, and to improve contact and expertise and awareness among interdisciplinary team members. In the 1990s, you can see that a lot of residencies and medical students didn't have any exposure to terminally ill patients or to how physicians dealt with terminally or chronically ill patients. In the year 2000s, actually exposure improved, and a lot of medical schools reported that they had about 4 to 14 hours of curriculum in palliative care, or at least addressing end-of-life care issues. LCME and AAMC, which are the regulatory organizations, demand that you have end-of-life care. This is what we used to have, because before this course, you had one lecture, you had random exposure of the wards, and then you had an elective course that 10% of you will take. Then we did a survey in the year 2008-2009, and a lot of you said that, your colleagues before yourselves, said that many of you did not have exposure to communication issues related to end-of-life care. So they weren't able to initiate a DNR discussion. 40% of the students believe that they didn't have training in pain management or palliative care, and 31% of the students believe that they didn't have enough end-of-life care training. So that's why this project came about, and that's why we're focusing on communication skills, on interdisciplinary teams, and the multicultural practice of medicine. This is what you have been going through, the longitudinal curriculum that you have experienced, giving you approximately 30 hours of instruction in palliative care. MS1, if you remember, were you here? Family members interviews? You remember? No? You were not here? You were? Goodness. Okay. I think you were the first year that had the bereaved family members. They came and spoke in small groups. Okay, that was my recollection. MS2 had pain management, so there were patients that came and spoke with you about their different issues with pain. MS3, we had palliative care day. Did you have palliative care day? Yes. Good, okay, something else. Palliative care day, which you had exposure to delivering bad news, pain management, and then hospice visits. And then this is the mandatory course in which we have communication, digital communication, family meetings, complex symptoms, and end-of-life care. We are going to be using Mrs. Flores throughout the curriculum, and you will be very tired to hear Mrs. Flores' case throughout this particular course if you have not already, talking about the different symptoms and the different issues that she has with her family as her end-of-life approaches. We're going to be talking about interdisciplinary teams now, and I cannot emphasize enough the importance of having interdisciplinary team members working with you when you care for very sick patients. Interdisciplinary teams are nurses, physicians, social workers, pastoral care, and others such as pharmacists or volunteers. And they work from different orientations and they bring different expertise to try to help your patient better. This is just a couple of the team members that we had in our team. And the idea is that we have special cases and we have a collective ownership of goals to try to come up with one plan of care. A good example of interdisciplinary care is the concept of total pain, and you may have heard of this before. This is Dr. Cicely Sandra, and Dr. Cicely Sandra is the founder of the hospice movement in the world. She was a social worker who realized that needed to know clinical stuff to be able to help with the patients to have their pain treated. And so she became a nurse, and then she realized that we physicians don't listen to nurses very much, so she became a physician. So she was a social worker and a nurse and a physician, and she's the founder of the hospice movement again, and she invented the concept of total pain. And in the concept of total pain, we have physical pain, which is the one that we're going to focus on a lot, and we have physical pain, and we have dyspnea, and we have different GI complaints, and we have fatigue and anorexia. But we also have what we call emotional pain, in which, like Mr. Trevino, he was having a lot of depression and anxiety, and that was affecting his physical symptoms. And then we have spiritual pain, finding meaning, finding hope, trying to finish what we call unfinished business. For some people, it's religion. For some people, it's spirituality. For some people, it's just finding meaning to your life. And then social pain, which is the small cores and different finances issues and isolation issues. So if you think about it, the emotional pain and the social pain sometimes are pretty intertwined. As you saw Mrs. Delgado and Ms. Villagomez here today, we would not be able to be a team without family members. Extremely important that you contact the family at the beginning when you admit the patient and you see what is their situation, how can we help. So in conclusion, palliative care is beneficial. It reduces symptom burden. It improves patient and family satisfaction. It reduces cost. And it is a growing subspecialty and field. It is beneficial because it helped with emotional and spiritual support in different studies that have been done. It improves communication, so we hope that you learn communication throughout this course. We hope that you learn how to care for terminally ill patients, particularly at the moment of their death. We hope that you know how to access services in the community, how to take care of yourself and how to take care of your patients. And we also address PTSD symptoms. Do you have this on your syllabus? So we're just going to go over the schedule really quick. We had 1 hour lecture, and that's all I asked for you. That was today. That's done. I won't see you anymore as a large audience, because I know you hate that. So we're going to continue doing small groups. That's coming up on March 21st. We will have a complex pain management. Everything is going to be case-based. We continue with complex communication, in which we will be distributing the different roles to pursue a family meeting. That will bring us into our online modules that you can complete at your convenience. The only module that is not available yet is the complex communication. Should be available by the beginning of next week. We have the non-pain symptom management and the last hour module available. And then we'll have a complex communication clinical encounter in which you will be practicing how to lead a family meeting. So we will have standardized family members and you will be practicing that. Not only that, but you will also get direct feedback, which I don't think you get a lot when you do these clinical encounters. These are the different evaluation methods on your right side. So completing the pre-test was a requirement for right before the lecture today. So hopefully you did that. Attendance. So this course is not going to evaluate you with testing or with scores. It's basically an attendance and participation course. So just to attend the activities and to participate will get you to pass the course. On the different modules and activities, you have a pre and a post test. This is just to evaluate your progress for us to hopefully improve the course for next year. You will have an evaluation at the end of the course, which will be should be completed by April the 8th. April the 7th is the last encounter for this particular course. This is Mrs. Flores, and you're going to get to see her in different videos and different online modules as well. I wanted to see if there are any questions in regards to the lecture, the course. Yes?
It's actually not about the course. Well, I'm actually wondering if you're at a disadvantage applying for the Palliative Care Fellowship as a psychiatrist versus a medicine doctor, or how does that work?
That's a great question. I'm going to repeat it. The question is, if you go into psychiatry, are you at disadvantage in applying for Palliative Care Fellowship in the future? The answer is absolutely not. Palliative medicine has become a new subspecialty at the beginning, I think in 2008. And with that, 10 specialty boards sponsor the fellowship. So you can come from pediatrics, you can come from anesthesiology, from psychiatry, from internal medicine, family medicine. We can come from neurology, GYN, rehab. I think I mentioned most of them. So if you wanted to become a palliative care specialist in the future, you are not at a disadvantage at all. We take a lot of internists and family physicians because they have a particular interest, but not because we don't take other specialties. As a matter of fact, our incoming fellows, we have one surgeon and one anesthesiologist. Any other questions? Yes? That would be midnight the day before the complete communication, so the 23rd. By midnight on the 23rd. Is that? So Wednesday, Thursday? No, I think it's Tuesday, Wednesday. Yeah. Because Thursday is the activity for the complete communication. Any other questions? Comments? Mr. Trevin, is there anything else you want to say? We're very thankful for your presence. Thank you very much. I forgot, if anybody did not sign in today, the only way I have to know if you were here is by signing in. So you need to sign in, okay? And you must have had an excused absence if you weren't here today. Thanks. So you can pass that on to your friends.